For our first 10 rounds presentation, we'll have Ankur Choksi. He's a fourth-year medical student at the University of Maryland. He's originally from Edison, New Jersey. He went to Rutgers University. He has interest research in the development of novel nanoparticles for biomedical applications. And outside of urology, he's interested in cricket, Topgolf, and foreign cinema.
Good morning, everyone. Thank you for having me as a sub-I for this past 3 weeks. My name is Ankur Choksi, and I'll be talking about the role of artificial intelligence in urology. So currently, I don't have any financial disclosures. And what artificial intelligence basically is, it's taking these computing systems that are capable of taking information from the environment and then acting on that data to basically perform a task that's set out to go and try to optimize that task in whatever way possible. Artificial intelligence is pretty prevalent throughout our personal lives. For example, the first thing you do when you wake up in the morning is check your phone. Face ID is using artificial intelligence to unlock your phone. If you have a Tesla and you come into work in that Tesla, then it probably has some form of self-driving capabilities as well. And if you're into fantasy football, Watson recently has been using projections from its data source to kind of predict what the best lineup would be for you to win your game. Additionally, artificial intelligence is also prevalent through our healthcare environment as well. It's estimated by 2021 that approximately $6 billion will be invested into research for artificial intelligence, specifically for healthcare alone. I think it's important for urologists to know about artificial intelligence because it's estimated that about $40 billion will be produced in revenue by the influence of artificial intelligence into robot-assisted surgery. That puts us as leaders in the spotlight of changing the dynamics of the healthcare environment. I wanted to give this talk basically to kind of describe some of the current and future applications in the field of urology and just kind of inform you how artificial intelligence works, just so that we're all well prepared to kind of address this going forward. So I divided this talk into A, how artificial intelligence works, and then talking about the current and future applications. So let's get started. The first is expert systems, and this is kind of basically taking a rule-based system into how we kind of make decisions on a daily basis. So for example, let's say we have a knowledge base, and that knowledge base is, for example, the AUA guidelines or the NCCN guidelines. These are a set of rules that the computer will use, and then using a series of if, this, then that statements, it will basically provide some form of clinical decision support. Let's say we take some patient data, the artificial intelligence software is able to basically comb through these notes and kind of determine what's important and what's relevant for it to act on its rules. It provides us some information such as treatment algorithms, or if we need further workup to kind of get to the point where we need to be. Machine learning is a more, I would say, a higher order level of artificial intelligence. It's able to actually learn from every time we challenge it with information and optimize its future projections. And there's two forms of machine learning. The first is supervised learning, and the second is unsupervised learning. Supervised learning basically takes that machine learning algorithm, and we have to train it with some data. So we provide some information with labels with that data. For example, let's say we wanted to give it images of MRI images of the prostate. We would tell our algorithm that we're providing this information to this system. You can learn from this system, and then please help us out with this question. So for example, let's say I gave our algorithm, after training it, an image of that MRI image that I have on the bottom below. It'll be up to the algorithm to determine, is that prostate or is that not prostate? Do you guys have an idea of what that is? Is that prostate or not prostate? Yeah, that's not prostate. That's actually just the head of a femur. And then there's another form of machine learning, which is unsupervised learning, and it's also known as deep learning. And basically, this is probably how we think. We don't have to be trained. Sometimes we can just perceive information and recognize patterns that are evident throughout life. And this is exactly what it does. We provide it a data set. It kind of learns what the patterns and structure is of that algorithm. And then the algorithm then learns how to manage that data and provide the best information. So for example, it's able to, let's say I have a pack of M&Ms. It'll basically tell me what color M&M I have without me telling it what color it is. So that's something to look forward to. And that's what most of the future applications are currently being based upon. And then a subset of machine learning is artificial neural networks. This kind of mimics how basically the biological applications of our own nervous system. It takes inputs from various variables and acts on those input neurons and does some form of computational process, then passing that on to another layer of neurons, another form of computational process go on, to finally give us a binary output. This is really a black box. No one's able to really describe it just because of the complexity of the layer of neurons involved in this machine learning algorithms. For any artificial intelligence application, the Turing test is required. And what that basically is to determine whether this artificial intelligence platform is capable of doing human-like information or processing. So for example, let's say we wanted to take our artificial intelligence system and test it if it's capable of tricking me into thinking I'm talking to a chat box. So this was actually where it first developed. So a human user was given two different chat boxes, one by a normal human, another by an artificial intelligence based program. And it was supposed to determine whether the human was able to differentiate whether I was talking to a chat box or an actual human. And that's where this Turing test basically applied. So I'll be using this Turing test to basically go through all the applications that I'll present and kind of determine whether this is actually able to perform some form of capabilities that we're capable of doing. So I'll start with the current applications of AI in neurology. And by current, I really wanted to focus on 2015 and onwards. That's where we start to see some of the more higher order artificial intelligence platforms. And this was made possible because of the availability of big data and advancement of our machine learning algorithms and our growth in our computational powers. So the first, which I'm sure you're all pretty familiar with, is natural language processing, such as speech recognition software. It's basically used quite evidently throughout the operation room after a case is over to dictate notes. It's also being used to go through our research notes to see if we can pull information from our medical notes and kind of use that towards research purposes. And when the Turing test is applied to this application, it says that the accuracy of the software is anywhere from 75% to about 98%, which is pretty good because we as humans sometimes make mistakes as well. So we're not trying to be perfect with this, but it is pretty close to being where we want it to be. Another thing is looking at prostate cancer pathology. There's an artificial intelligence software that's able to look at the pathology slides and kind of determine the automatic Gleason grade. The reason this is important is because there's a lot of controversy whether pathologists have assigned the same Gleason grade every time they look at an image. So there's a lot of inner observer variability. So hopefully the goal of this was to kind of streamline this and see if there's an automatic grading system. So using this platform, they trained it with 330 pathology slides, and it was basically analyzing it for tissue type, glands, and nuclei. For each feature, it was assigned a weight, and the algorithm was designed based on how that correlated with a Gleason grade. Then an experimental data set of 230 pathology slides were given to this diagnosis system. And if we apply the Turing test to this platform, it was 51%. And that might seem pretty weak, but if we look at the inner observer variability between pathologists themselves, it ranges anywhere from 45 to 62%. So this falls within that variability. Another application was taking bladder cancer chemotherapy response. So the software is able to read CT scans and determine whether a patient with bladder cancer that was treated with neoadjuvant chemotherapy received pathological response. So again, it was trained with a data set of 80 CT scans which had a stage associated with that CT scan. And an experimental data set of about 40 CT scans were given to this platform and kind of decide whether the patient was able to reach PT0 or not. And when we applied the Turing test to this, it was actually pretty good. It received about 95% correlation with radiologists as well. The only downside to this is, I'm sure you all know, CT scans aren't the gold standard for kind of determining if a patient received PT0 or not. The AI system was about 73% accurate when compared to the final pathology specimen from a cystectomy, but the radiologist was no better, about 77%. I'm sure you've all, if you have used the SI simulator or the XI simulator, you might have been exposed to this AI platform. It's just evaluating your skills. So basically, it tracks the Cartesian coordinates on both of your hands and it's able to differentiate if you're an expert surgeon or a novice surgeon. Basically, what they're looking at is the continuity of your motions, the smoothness of your motions, the time it took for you to complete the actual experiment. And the goal of this is to create a curriculum based on the movements of the expert surgeons to train future novice surgeons. AI is also used in urologic oncology as well. Many of these platforms were kind of developed in the early 2000s, and they were based on more of the expert decision making systems that I presented before. But what I really want to talk about is IBM Watson. This was introduced in Memorial Sloan Kettering, MD Anderson back in the early 2010s to 2015s. And it was designed to help oncologists make the best treatment decisions for their patients. And so they took a data set of 30,000 patients at Memorial Sloan Kettering and kind of matched those patients to known patients within their own system and also the existing literature that exists on NCBI. And the goal of this was to kind of help provide treatment options to these patients, new patients that come into these cancer centers. So the Turing test applied to this application is actually unknown. There's actually been quite talk whether IBM Watson was pushed way too early into the healthcare environment and whether they kind of produced a half-baked product before it was actually ready to be exposed. MD Anderson also had a Watson at their facility, but they closed, citing reasons as inaccurate treatment options and just a lot of bias in trying to obtain the best treatment options for their patients. The shortcomings and challenges with AI is if you put garbage into the system, it's going to put garbage out. Just like our own intelligence is kind of flawed by perceptibility to bias, AI is also prone to bias. If there's a systemic bias in the data set, it's going to show in the outcomes as well. Also, liability is a big question here. If something were to go wrong and it affected patient care, is the manufacturer of the AI system responsible, or is the physician using the AI responsible? Also, questions about data security and HIPAA compliance, as well as correlation and causation, also provide some challenges to getting AI into the marketplace. Also, the biggest question is overuse. And it's been that AI has a lot of hype right now. So a lot of individuals create an experiment or a platform for AI, even though it's not necessary. And this overuse tends to go towards the downfall because we inflate expectations so high that our computing systems might not have reached that capability. This happened in the 1970s, but now we're in the 2000s and we have a revolution of AI. Lastly, I'm going to talk about the future applications of AI in urology. So this one was pretty cool. What these researchers did was they observed all of the radical prostatectomies done robotically. And then for each stage of that procedure, they were able to assign a grade based off how the performance was. And then they were able to determine with 87% accuracy whether that patient was going to stay longer than 2 days. So this is something that we'll probably see within the next 3 to 5 years. It's still in its infancy, but it's very exciting to see. Next is smart tissue autonomous robot, and this is probably the scariest part because they were actually able to get a robot to complete an intestinal anastomosis in a porcine model. So with this, they use near-infrared markers, and they inject along the tissue line that they want to suture at, and then their suturing algorithm will then interpolate between those points to basically create a suturing plan, and I'll go ahead with it. Right now, the thing to basically calm some nerves, it takes about 60 minutes for them to do one of these anastomoses compared to 8 minutes for a human. So it's still in its very early steps, but this is something that we should also expect to do. Maybe such as when Ford released its car that was able to parallel park on its own, kind of expect something similar to this. If you're done with the procedure and just need a suture to be thrown, press a button and that suture will be thrown for you. This is something maybe to expect in like the next 10 years or so. And then lastly, Alphabet, which is the parent company of Google, and Ethicon is coming together to form a robot of their own known as Verb Surgical. And basically what Verb Surgical provides that DaVinci currently doesn't provide is Google's expertise in informatics. So for example, let's say a surgeon is having a difficulty with a procedure. The AI system within this robot will be able to basically go through and observe how other surgeons were able to perform this step and then provide hints to the surgeon and say, this is the plane that they targeted, or they said, maybe the other surgeons worked on this other area of the surgery and maybe you should come back to it. So basically providing real-time advice if the surgeon has some complications. It's also supposed to have some overlays that will show critical structures. So maybe the ureter will be less damaged in other surgeries as well. these are the current clinical trials that are ongoing. Currently, most of them are focusing on the radiomics, so basically looking at radiology and artificial intelligence as well. And then there's also a trial using AI to match patients with cancer with the best clinical trials that are currently in process. And just to, again, quell some nerves, there's still a long time before a lot of AI is going to come into the marketplace. We're expecting a lot of these to come in the next 2 to 5 years, but I'll be their infancy steps. It's not going to be a fully formed product. So we can expect AI to probably come into use in 10 to 20 years. So in conclusion, I just wanted to express that I hope I convinced you that AI is a valuable tool to improve patient care. There's many of these tasks that we can introduce into our daily professional lives to help us assist and do what's more important for us, and that's taking care of the patient. And because a lot of this will involve collaboration of physicians with data scientists, I think we should take the first step forward in making sure that we have our say and express our needs with how AI can help us. And lastly, I don't think we'll be replaced by AI anytime soon. Within our healthcare team, there is no I in our team. I think it's time we add AI to our healthcare team. Thank you. Do I have time for any questions? Dr. Sprinkle?
So I guess the bigger picture with AI, I mean, you know, I guess taking away from medical AI for a second, but there is the concern of somewhat hysterical concern that AI is going to sort of take over and supersede us, not only in technology, but sort of just overall. I mean, sort of the AI apocalypse. I mean, what is your take on the reality? I know there's a lot of controversy, like Elon Musk thinks that's a real thing, but Jeff Bezos says it's ridiculous. So, you know, I mean, what's your take after all of your research?
So basically, I think that's a good question. That's definitely a possibility. At the end of the day, we're the ones creating the AI. So we could put check marks and safeguards to prevent that from happening. But at the end of the day, what makes AI so unique is it takes information, acts on it, and then betters itself. So there is enough, it could actually become, and we might be in a situation where that were to occur. But at the end of the day, since we were the ones that created the AI, we should be able to prevent it from going to that. So that's something that we should be considering when creating these platforms. Dr. Liebman?
Yeah, great talk. So one question is, you know, you mentioned bias, right? And I think that's a real concern because these systems, I mean, even though you can develop an unsupervised system, which is going to potentially gain new knowledge, it seems like more often than not, we're reinforcing knowledge that we already have. So some of the systematic biases, institutional biases could be perpetuated. To what degree can we develop new, like, discovery versus reinforce kind of what we already know? And maybe maybe reinforce guideline concordant care as opposed to actually fostering new discoveries. You know, maybe you can just say, indicate to a clinician, okay, do this guideline.
I think that's where we're currently at right now.
Is the guideline, how would you, is there a way forward to actually create a better, anticipate what a clinical trial might show ahead of time, or?
I don't think that would be possible, but I think what would be is taking AI to further research. So to take the best patients that would provide the best information for us and assign them to write clinical trials, or just working with AI to make research more efficient so that we can get a lot of these clinical trials faster into the healthcare environment. But I don't think it would be possible for it to go ahead and make predictions without the correct information being fed into it, if that makes sense.
Machine learning. Necessarily doesn't. We don't know the.
Yeah, exactly.
It's not the recent.
Some other.
Facet.
Exactly. Yeah. So. Possibly, but at the end of the day, it would only be correlations and not causation, because it's all just based on statistical processing. But definitely, the way like unsupervised learning would work would be to just take every variable and then basically differentiate it, kind of create like these cluster plots and see where the clustering is occurring. So that definitely is a good point. Thank you.
Several layers, right? So image analysis, analytics, and then actual diagnosis. I think that's kind of the evolution. We've done a lot in image analysis. I think predictive analytics, integrating that is the next area, and then through automation of decision support is hard. And I'll tell you, I was actually just at Verb last month.
Okay.
They have a new CEO, and they're struggling because they have all this technology, they don't know what to do with it. And even Google Health is taking a step back because they're trying to understand that all these tools that can measure human health, blood pressure, and how to integrate it all so that we can use some form of AI or machine learning to help predict or actually drive variability. It's unbelievably
Exciting.
but very difficult. But I think your point, at the end of the day, we have to be involved. Because what I realized is that there is a chasm between the
Data scientists and
data scientists and the health
the physician.
and that's really where we provide some clarity. Because this is great to understand this in depth is very difficult, but we understand the patient side.
Exactly.
Another question for you and also for Peter. You know, it seems like, I know I sound very old asking this question, okay, but it seems like as we become more, you know, dependent on technology and on laparoscopy and on robotics, it seems like we're training generations of young surgeons that don't know how to operate like our predecessors did, you know, and I wonder if there's any way to go and retrospectively look at what are the outcomes of patients in the era when, you know, graduating chief residents did like, you know, 1,000 open nephrectomies and cystectomies. And now I think we're training generations of physicians that don't really know how to do open surgery anymore. And there's going to be a role for that going, you know, down the road. What happens when your robot doesn't work, you know, or there's something else going on, you know, the suturing is, you know, the automatic suturing just falls apart.
I think what you do bring up is a good point, is when technology fails. I think we are pretty weak humans because we haven't been trained in the aspect that our predecessors have been. But I think overall we're headed towards, what we do care about most is not how good surgeons we are, but how good the patient feels after the surgery, or how the patient's outcomes are. As long as we're heading that trajectory where patient outcomes are improving, I'm okay with being not as proficient of an open surgeon compared to some of the physicians that trained before me. But as long as the patient's outcomes are improving, I'm okay with taking that step back.
I would argue it's the opposite.
Yeah, a little
Yeah.
That's great.
Yeah.
All right. So next we have Alan Cruz, who's originally from San Diego. He went to UC San Diego along with Jeannie. And now attends the University of Michigan for medical school. He completed a Master's of Science in Clinical Research. Some of his interests include oncology, health disparities. In his spare time, he enjoys soccer, exercising, listening to NPR, and watching Michigan lose on Saturdays.
So the title of my talk is Post-Finasteride Syndrome, New Side Effect Concerns and Controversy. I have nothing to disclose. In this talk, I would like to start off by providing a brief introduction into 5-alpha reductase inhibitors, and then most recently into post-finasteride syndrome. I would then like to proceed to talk about the origin and evolution of finasteride concerns and the androgenic alopecia patient population to provide a historical context to current research in benign prostatic hyperplasia patients. So as you're all aware, 5-alpha reductase inhibitors are commonly utilized in the treatment of BPH and androgenic alopecia, otherwise known as male pattern baldness. They function by blocking the conversion of testosterone to the more potent dihydrotestosterone and thus exert their physiologic effects in the prostate and in hair follicles. Finasteride is the first medication in this drug class, and it was approved in 1992 for the treatment of BPH, and then in 1998 for the treatment of androgenic alopecia. Today, there are over 10 million prescriptions of finasteride in the United States. Dutasteride is the second medication in this drug class, and it was approved for BPH in 2001, and is currently used off-label for androgenic alopecia. As mentioned, these medications function by decreasing serum dihydrotestosterone, and thus lead to a decrease in prostatic size, improved urinary flow, and a reduction in lower urinary tract symptoms. Early clinical trials have also shown that they lead to a reduction in the amount of episodes of acute urinary retention and also in the need of prostatic surgery. Commonly known side effects from these medications include impotence, decreased libido, ejaculatory disorder, and gynecomastia. But since 2011, there have been more than 1,400 lawsuits filed against the pharmaceutical company Merck over the 1 milligram dose of finasteride, otherwise known as Propecia, which is utilized for treatment of androgenic alopecia. The term post-finasteride syndrome was created as a way to describe the constellation of sexual, physical, and psychological symptoms that began during or after finasteride use and persists after its discontinuation. In 2012, there was the Post-Finasteride Syndrome Foundation was created to fund research into its underlying biological mechanisms, treatment, and also to raise awareness. As you can see here, the website contains up-to-date information on adverse drug reactions worldwide. They claim suicides, nation's warning on post-finasteride syndrome, and other things like research studies published to date and national media reports worldwide. So how did all of these concerns begin in the androgenic alopecia patient population? Well, in 2002, there was a case series published by Altimer et al. In which he reported on 19 patients who developed moderate to severe depression 9 to 19 weeks after initiation of finasteride. These patients had resolution of symptoms after the medication was discontinued, and in 2 of these patients who were retrialed on finasteride, they had a recurrence of symptoms. 4 years later, in 2006, there was a prospective trial following over 100 androgenic alopecia patients who were assessed for depression scores and anxiety scores through the Beck Depression Inventory and through the Hospital Anxiety and Depression Scale. They found that depression scores worsened in these patients who took finasteride, and there was worsening of anxiety as well, but this was non-significant. And then in 2012 and 2014, by recruiting patients from propitiahelp.com, Erwig conducted a standardized interviews of over 60 patients who were former users of finasteride and compare these to control patients who had androgenic alopecia in the community. He found that previous finasteride users endorsed more depressive side effects, and 40% of these patients reported suicidal ideation. In a second study, he, again from patients recruited from propitiahelp.com, he examined for persistent sexual side effects in patients who had persistence of sexual side effects after at least 3 months after discontinuation of finasteride. He found that 95% of these patients continued to report sexual side effects with a mean follow-up of 14 months. And then most recently in 2018, there was a paper published in which they examined the FDA's adverse event reporting system. It should say from 2011 through 2014 for the 1 milligram versus 5 milligram dose of finasteride. What they found was, as you can see here, that the 1 milligram dose adverse event reports trended upwards, especially after the FDA announced mandatory labeling changes to this medication, whereas the 5 milligram dose remained steady over time. When breaking down adverse event reports by symptom category, they found that the 1 milligram dose had higher reported, higher percentage of all three symptom categories. So what does this mean for our BPH patients who, in regards to these sexual, physical, and psychiatric side effects? They do take a higher dosage of this medication. Well, in a nested case control study published in the British Medical Journal, Hagbert et al. Compared over 70,000 BPH patients who were started on 5 alpha reductase inhibitors versus alpha blockers and combination therapy. He did not find that there was any increased risk of erectile dysfunction in these patients compared to the alpha blockers. Interestingly, he did find that what was associated with erectile dysfunction was the rate longevity of having BPH. In this secondary analysis of the PCPT prostate cancer prevention trial by Ankur et al. Published in 2015, he looked at Medicare claims for patients in the finasteride versus placebo group, and he did find that there was a 10% increase in claims of depression in the finasteride group, but no increase in claims of erectile dysfunction. And then in 2017, this paper published in JAMA Internal Medicine examined the psychiatric concerns of finasteride of 5 alpha reductase inhibitors on BPH patients by, they were looking to see if there was an increased risk of suicide, increased risk of depression, or self-harm. What they found was that in the first 1.5 years of finasteride of 5 alpha reductase inhibitor use, there was an increased risk of self-harm and depression. Depression risk remained elevated throughout the study, whereas self-harm was no longer elevated after the 1.5 years. Unfortunately, their suicide outcome was underpowered, and they could not assess for this. When looking at the physical and metabolic side effects of finasteride in BPH patients, the paper published this year by Wei et al. In the UK looked to examine if the risk of the incidence of diabetes was increased in patients on finasteride or dutasteride versus tamsulosin. What he did find was that dutasteride was elevated by 34% during the study, but not finasteride. Other clinical research has shown that dutasteride, blocker of the 5 alpha reductase type 1 enzyme, which is present in the liver, leads to hepatic steatosis, and there's also expression in adipose and muscle tissue, which could explain some of these metabolic side effects. In conclusion, post-finasteride syndrome is an ill-defined condition comprising of sexual, physical, and psychiatric side effects. Low-quality research in the androgenic alopecia patient population has led to controversy on its existence, but newer research in BPH patients appears to show an increased risk of depression, diabetes, but not erectile dysfunction. These are my references, and thank you. I'm happy to take any questions. Yeah, so in that paper published in JAMA Internal Medicine, I think they tried to do like a secondary analysis on that, and they did not find any increased risk, but I thought that it was maybe a little bit underpowered for that.
I noticed that in one of your graphs that there was an increase in the incidence of side effects with the 1 milligram dose.
Yeah.
5. Why do you think that is the case? Okay, go on.
Yeah, so first of all, there was this labeling change that was given to the 1 milligram dose. And there was a randomized clinical trial that showed that if you tell these patients that these might be side effects that they may experience, they also have elevated reporting. In addition, the 1 milligram dose is usually used in a younger patient population, usually between 20 and 40, whereas a 5 milligram dose is used in BPH patients, which over 50. And we might not be asking our BPH patients, or we might not be aware, so this might lead to a decrease in reporting. It was interesting, though, that they did mention that the 1 milligram reports were only 17% of these reports were done by healthcare providers, whereas in the 5 milligram, 40% of the reports were done by healthcare providers.
So I think you answered my second question, and that is there an age difference? Are you more likely to have these side effects if you're younger versus older, which would maybe also explain the difference?
Yeah. We might not ask an 80-year-old if he's having erectile dysfunction, or they might not be as concerned. That's a possibility too.
Well, one final note. When we did the MTOP study many years ago, I think you mentioned that. And one of the problems with keeping the patients in the trial was sexual dysfunction. And in order to keep these gentlemen in the trial, we were prescribing Viagra. Because again, once you tell somebody something can cause erectile dysfunction, all of a sudden it happens. And it turns out that when the study was unblinded, there really wasn't much difference between those who were getting placebo versus finasteride. So,
yeah, I know, like I mentioned on this retrospective study, that didn't find that there was any increased risk of erectile dysfunction. One of the points that they make is that in the early clinical trials, they mentioned that these patients were undergoing surveys, constantly asking about these symptoms and all of this stuff. Whereas here, we're only looking at clinically significant erectile dysfunction. So as patients who reported this to their provider or who required a PDE5 inhibitor.
So I guess two questions. Do you know if there's any affiliation or conflict of interest in these websites, Propecia Health? It seems to have a legal bend to them.
Yeah.
The other question is the comment on the sort of growing rise of direct-to-consumer targeting. Maybe they're just targeting me for Propecia. I don't know. I don't know why that would be. But but there are these companies that are Keeps and Hims that we're actually beginning to look at some of how the language used in the marketing, because that's a big push now to younger patients. So these are kind of two competing forces.
Yeah, I mean, I definitely think that there might be some legal aspect to the website. I think, well, the genetic and rare disease part of the NIH acknowledged that there was there might be some concerns with post-finasteride syndrome, but they haven't actually said that it's a real disease. So obviously these websites are run by people who they might be trying to promote their yeah, potentially. And then your second question was, sorry. Yeah. Mm. Yeah. Yeah. I mean, I've been getting stuff on Twitter too from all these pharmaceutical companies. Yeah. Yeah.
So I had never heard of that foundation before, the post-finasteride syndrome foundation. So I just quickly looked them up. Their board of directors has 3 members, one of whom is a lawyer whose specialty is med-mal, and who has a med-mal class action company.
Yeah.
So.
Yeah. So again, lower evidence research in the androgenic alopecia patient population, it's hard to tell if this is real, but there does seem to be some effects in the BPH patients based on these retrospective studies. But again, they are retrospective too. Mm-hmm.
So based on what you presented this morning, I have 2 questions. One, should we be changing our prescribing practices? And 2, if not, should we at the very least be providing disclosure?
What was the last part?
The second is providing disclosure to the patient in terms of potential side effects.
Yeah. I don't think that we should be changing our practice. I think that it's important to be aware of these potential side effects of finasteride. So I definitely believe that we should disclose that there might be an increased risk of depression, and that we as providers should, again, be aware of these side effects and maybe even ask our patients if they're experiencing them, because who knows, maybe depression is a bigger issue than we think. We're just not really asking about it in our patients. So, yeah. The absolute increase in like